morning and welcome to this September meeting of the Shropshire Health and Wellbeing Board. I'm Val Cross, Health and Wellbeing Strategic Manager, and the first item on the agenda is election of the chair for this meeting, as Simon Jones is unable to be here for the whole meeting. Can I have a proposal for the election of Simon Whitehouse, CEO of the Integrated Care Board, please? Thank you, Tanya. And a seconder.
I'll second.
Thank you, Simon. Thank you. I'll now, I should have said I will take a vote on this, which I've just done. I'd now like to welcome Simon Whitehouse as the chair for this meeting, and we'll hand over to him now. Thank you.
Good morning, everybody, and welcome to the Health and Wellbeing Board meeting for Shropshire. I'm delighted to chair this morning, but great that Simon will be able to be here for the start of the meeting, but needs to leave during the meeting as well. For those that don't know me, I'm Chief Exec of NHS Shropshire, Telford and Wrekin, which is the Integrated Care Board across the Shropshire, Telford and Wrekin geography. Just need to inform everybody that we are live streamed and being recorded. So members of the public will be able to see the meeting and hear the audio, so be aware of that when we are presenting and when we're talking and when we're engaged in the meeting. For those in the room, when you want to speak, please press the button on the microphone so people can hear that over the audio. We'll start with those members in attendance, please, so we'll go round the room first and then we'll do those online. If you could state your name, role and organisation, and then we can just make sure we've got a full record of those that are here. So I'm going to start to my left and go round. So Rachel.
Thank you very much. Rachel Robinson, Executive Director of Health, Prevention and Wellbeing here at Shropshire.
Good morning, Penny Miles, Executive Director of People at Shropshire Council.
Morning. Morning, Penny Basin, Head of Joint Partnerships, Joint Roles, Shropshire, Telford and Wrekin ICB and Shropshire Council Public Health.
Morning, Pauline Wilson, Assistant Director for Integration and Healthy Population at Shropshire Council.
Good morning, Nicola Diamond, ICB Director for Strategy and Integration.
Good morning, I'm Councillor Cecilia Motley. I'm a Shropshire Councillor. I represent a rural area and I'm portfolio holder for communities, leisure, culture, tourism and transport.
Hi, I'm Jackie Jeffrey. I'm Chief Officer of Citizens of Ice Shropshire and I'm also the BCSA rep on the Health and Wellbeing Board.
Morning, I'm David Crosby. I'm Chief Officer for Shropshire Partners in Care.
Good morning, Councillor Simon Jones. I'm the portfolio holder for adult social care and public health.
I'm Val Cross, Health and Wellbeing Strategic Manager in Public Health.
Thank you. So I should have checked before. But nobody indicated otherwise. People online, you can hear us okay and see us okay. I'll take nods and thumbs up, so thank you for that. So Val, I just wondered with those online, if you could take us through and do the introductions for those online as well, please.
Yes, we've got Lynn Corley. Lynn, do you want to introduce yourself?
Hi, I'm Lynn Corley, Chief Officer at Healthwatch Shropshire, and my apologies for not being in the room today, but I'm giving a presentation to the PCMs shortly, so good to see you all.
And Ben Hollands, please.
Yeah, hello, good morning. I'm Ben Hollands. I am the Health and Wellbeing Strategy Manager at Midlands Partnership Foundation Trust.
And Chris Westwood.
Good morning, everyone. I'm Shropshire Council. I have the Customers Contact Centre, so we deal with all public contact, and there's a project on this board today that sits under my remit.
And Laura Fisher, please.
Morning all, Laura Fisher, I'm Head of Housing, Resettlement and Independent Living at Shropshire Council.
And Angie Wallace, please.
Good morning all, I'm Angie Wallace, I'm the Chief Operating Officer for Shropshire Community Healthcare.
And Rhiannon Morrow.
Hi everyone, I'm a GP ST2 trainee based in Shropshire doing the Population Health Project.
Thank you, and Shirley Ann.
Good morning, I'm Shirley Ann Carville. I'm Interim Director of Strategic Planning and Partnerships at SAF. Thank you.
And Andy Fox, please.
Good morning, everybody. I'm Andy Fox. I've got a joint role between Shropshire LA and Shropshire Telford and Wrekin ICB as Population Health Management Analyst. Okay, pleased to meet everybody.
Thank you, and that's everybody online.
Thank you, Val. Thank you, everybody. And Kirsty, you've just joined us, so would you like to just do a quick introduction, please?
Yeah, I'm Councillor Kirsty Hurst-Knight. I'm the Portfolio Holder for Children and Education at Shropshire Council. Oh no, sorry, David introduced me.
Thank you, Kirsty. Morning, everybody. Lots to get through this morning. Really good agenda. I want to make sure that we get the time for the conversations and discussions across all of the papers, not just those at the beginning and then squeeze the ones at the end. So I'll look to just keep the agenda flowing in that space, and your support in that will be greatly appreciated. Getting the balance right on a hybrid meeting is always a bit of a challenge, so bear with me whilst I make sure we try and bring in those who are online when they indicate they want to speak, as well as those in the room, and we'll just try and work through that as seamlessly as possible. We'll follow the agenda as been published online. There have been a number of additional papers that have come out subsequently. My plea on behalf of the team that do a fantastic job in terms of supporting the meeting would be for authors of papers, if we can try really hard, and I include my own organisation in this, in getting the papers in on time. That means then when the pack's published, it's one full pack of papers that just makes it easier for everybody going forward. So we don't want to make it any harder than we have to for the colleagues who try and make sure that these meetings run smoothly. So thank you to everybody for that going forwards. If I follow the agenda through, I'm initially going to do any other apologies. So we have received apologies from Stuart Bill in terms of West Mercia Police, Nigel Lee from SAF, but Shirley Ann is covering, Patricia Davis from Shropshire Community Health, but Angie is here covering for Patricia. Have we received any other apologies?
No.
Thank you for that. Moving through then into agenda item 3, which is the disclosable interests. Members are reminded to disclose any pecuniary interest in any matters to be discussed which is not already included in the register of interests, and to leave the meeting prior to that matter being discussed. Other than those that are already on the register, does anybody have anything that they wish to declare relevant to the agenda today? I can't see anybody indicating anything in terms of that. Thank you for that. Okay, minutes of the previous meeting. We've got 2 sets of minutes to go through. So we've got the minutes of the 19th of May, which was in the pack, and we've got the minutes of the 14th of July, which were sent subsequently. I'm going to go through these at some speed, but on a page-by-page basis. I'm going to do the 19th of May first, that were in the first poll pack that were published. The minutes for me start on right at the bottom of page 1, page 2, page 3, page 4, page 5, page 6, page 7. Lynn, sorry. You're on mute, Lynn, sorry.
You're just about to get to page 8, which is the page I was going to ask about. And
there's a skill there, in preempting the fact that after I've done 6 and 7, you're absolutely right. I was going to go to page 8 next.
I thought so. My question was about the comments regarding the Children and Young People report that I presented in that meeting, and it talked about there being a meeting convened of the Children and Young People System Partnership Board, and I just wanted to follow that up because as far as I'm aware that meeting hasn't happened yet, and I just wanted to check that I'm right on that that hasn't taken place.
There is one in the diary, but it hasn't. There is one in the diary.
So Lynn, people are saying it hasn't taken place. There is a comment to say that people think there might be one in the diary. What I would ask then is, as an action from this meeting, to clarify the minutes, if we could circulate a note to say if the meeting has been arranged, when the date is. If that's not been arranged, if we could then subsequently arrange that and share that date with colleagues. Is that acceptable, Lynn?
That'd be brilliant, particularly if I could go along. That would be great.
Of course. Thank you for that. And Penny, you okay to pick that? Please. Thank you. Page 8, page 9. Lynn, you've still got your hand up. Is that a legacy hand? Yeah, okay, thank you. And page 10. Other than that note that we just picked up, people then happy for those to be an accurate record of the meeting that took place. Yeah, thank you. So then going on to minutes of the 14th of July. So I was not in attendance at this meeting, so we'll need some help, please. So Jackie.
Yeah, sorry. When did the minutes come out for that meeting? Because I can't. It's not gone on, has it? I can't find them in my inbox, so it's probably my fault because my inbox is very full.
So I think they. No. I think.
It was this week, was it? Okay, thank you. But I apologise, I haven't read them, so I can't.
And they were published online as well. But I think that's part of the point in terms of us getting everything together in one pack to make it easier for people going forwards.
Thank you.
So I'm going to go through these as well for colleagues that were at that meeting, please, in the additional pack. So page 1, page 2, page 3, page 4, page 5, page 6, and page 7. People happy with those as an accurate record for those that were at the meeting? Yeah. Okay, thank you, everybody. So moving on, next on the agenda would be public question time. We haven't been notified of any public questions prior to the deadline, which was last Friday, the 2nd of September. So I'm going to move us on again through the agenda, if that's okay. System update. The urgent emergency care plan has been deferred to the next meeting, but we are then going to pick up the ICS and ICP update, which is on the agenda. That was also circulated as a subsequent paper. That was emailed out towards the early part, the end of last week, actually. So hopefully people do have a copy of that. But Nicola, I'm coming across to you to provide that update.
Thank you, Chair. And yes, this paper is asking the board to note details within the paper. And yes, this is an update to provide more information on where we are with the establishment of the statutory functions in the ICS. And today, really specifically that of the integrated care partnership. There has been quite a bit of information released in the last few weeks from NHS England and in other media sites around the roles of ICPs. Just sort of for the benefit to try and condense some of that information and make it all a little easier, I guess, to take on board, we put into the paper a little bit of a diagram and a picture sort of breakdown of the key points to know around the integrated care partnership. The ICPs in the new arrangements will play a really critical role, of course, to bring together health leaders and local authorities into a system level arrangement where they can start to think out of the box around some of the solutions for health and well-being and addressing any inequalities across the patch. And for us across Shropshire, Telford and Wrekin, that includes both of our local authority areas, and by virtue of that, the two health and wellbeing boards that sit within it. In terms of next steps, and I appreciate I'm probably repeating some of what we've talked about before, but part of the role for the integrated care partnership is to develop going forward the interim integrated care strategy for the system. And the benefits of that are about bringing those partners together with all the information that we have, the work that's been done through the health and wellbeing boards, through our constituent members and community knowledge, and bringing that to what we understand are some of the long-standing health issues that we're already aware of. The importance, I think, of completing that bit of work and timelines, just to note, are that we have until December to put the initial interim plan for the ICP together. It's not a lot of time, and I think kind of across the system people have been very conscious about that. However, given that we do have the 2 health and wellbeing boards, we have the work that's been going on at local level with SHIP, with TWIP, we have a lot of work already done within our systems and intelligence to bring together into this plan. The ICB will have an ongoing role then in taking the work from the Integrated Care Partnership in the shape of that interim plan and starting to look forward then on the longer term 5-year forward view of what the priorities are, how we take that forward, and how we start to work differently in a real sense with our partners across the patch on that. The hope for the first inaugural ICP meeting is that will be chaired by Telford Local Authority, and I think we've got a tentative date now, I think, for the 6th of October. It's been quite a challenge, I think, to get so many key important stakeholders in the room at the same time and bring that together. The terms of reference for both of the local authorities' health and wellbeing boards are being considered within shaping the terms of reference for the Integrated Care Partnership. That's been well and truly socialised and has moved backwards and forwards between those groups, and I believe we're very close to being able to release those draft terms of reference for the Integrated Care Partnership. So I'm happy to take questions on next steps for the ICP. We will hope, of course, that for the next meetings for the Health and Wellbeing Board, we will be able to discuss the first meeting of the Integrated Care Partnership, how that is gone, and how the work between now and December will work to pull all of that together. I will stop talking because I appreciate people will have read the paper and none of this is new information, but happy to take questions.
Thanks, Nicola. So let's take immediate questions and comments first. So Liv, online.
Thank you, Nicola. Just a quick question. My understanding is that Healthwatch is one of the members, should be one of the members of the ICP, but I haven't received any notification about that. So it might be something we can discuss outside of the meeting.
Yes, very happy to pick that up, Lynn. I know that the agenda or the membership or the admin support around that is in discussion as we talk. We do know that for the first couple of meetings, it's likely that the ICP may start off with a fairly core group of people, as much as anything really just to embed the process of where and how the meetings are going to draw information together, and then that will start to broaden over a period of time to sort of capture a much wider partnership agenda. So happy to pick that up with you offline, and given that we're aiming for the 6th of October, should be able to get some of that information out to you really soon.
Then if it makes you feel any better at all, I was quickly flicking through because that was a day to me, and it's not in my diary either. So, so don't take it personally at all in that regard. Any other questions or comments? So Rachel.
Thank you, and I think it was probably just a comment to again state, I think the obvious, I guess, for the board, that we've got there is a very tight turnaround in terms of when the ICP will meet and interim strategy policy needs to be developed, and this board meeting again, and so my expectation is, I'm guessing when we come together as a board in November or December, we've got a conversation on the date, that we'll be looking at probably a draft strategy. There's quite a broad, when I've looked at the guidance, there's a huge consultation within that, but you're right, we need to take a pragmatic approach that builds on the good work of this board, Telford board, and also our Switchenese as well, committees who've done, we've got a number of key priorities as well as the ICP. So it was just, I guess, to just raise that at the board to make a reassurance, but also I think that this will be a huge priority at the next meeting.
Yeah.
Absolutely, and I think Rachel, and that's a really good point, and I think that the next step of taking that interim integrated care strategy from the ICB, and as flushing that out into that longer term 5-year forward view, I think is where we have some really good opportunities to think about the co-design, to think about the engagement, to think about consultation. I think pragmatically we know the timeline between now and December is very tight, and we have to rely on the knowledge and the expertise to some extent, but I think it's important we don't see that as a final point. I really kind of keep stressing the interim and there's understanding this is really a blueprint process in many ways, that there's many more opportunities between now and March for the partnership to be talking about putting the meat on the bones with those initial priorities and plans. So we've got a much more developed plan between then and March.
Thank you for that. And I just, from my day job role, rather than sharing this morning, I just want to be really crystal clear. For me, this is about how we build on some of the great work that's already taken place across our 2 councils and in the system. This is not about starting with a blank sheet of paper and saying, please can we now write an integration strategy. We've got 2 really good joint health and wellbeing strategies. There's already some cross work across our patch anyway. A number of the organisations on this call and sitting around this table will be working across boundaries. We need to build on that, not say, how do we start again? So when we talk about what we're trying to do in terms of population health, what do we mean in terms of our 2 place boards, it's how do we bring that to life, pull that together in one place and articulate that, not how do we rip it all up and start again. So from an NHS perspective, it's very much about how do we build on what we've got. Tanya?
And just to add to that, we've got a workshop on the 29th of September. That's across SHIP and the Health and Wellbeing Board. So Nicola will make sure we'll get you invited, because it'll be a good opportunity for us to do that collectively together to feed into that ICP strategy. That's perfect timing, wonderful. Thank you for the invite.
Really helpful, Tanya. Lady, you still got your hand up. Is that a new point or is that a late hand? Okay, thank you. So I can't see any other indications for anybody that wishes to speak. So on that basis, the paper was self-explanatory and the board is asked to get to the right place. Note the detail contained in the report. To note the statutory requirements for ICBs and local authorities as core members of the system-wide ICP to develop an integrated care strategy. To note that this strategy must be informed by the work of the Health and Wellbeing Boards through engagement with local partners and communities, and to note proposed draft terms of reference of the ICP. So I'm assuming that, given the conversation we've had and the paper that's there, people are happy with those recommendations and we can accept those and move on. Yeah, good. Thank you, everybody. Thank you, Nicola. Moving through the agenda, also under agenda item 6, in terms of system updates, we've got the Shaping Places paper that is included for information. Members will receive this in their packs and it's published on the council website. The recommendation is that the Health and Wellbeing Board note the contents of the report, and I'll accept this unless members indicate otherwise. Rachel.
Thank you. I mean, I think it's a brilliant paper, and I just wanted to draw the board's attention to the paper, particularly in the context, I think, of the wider cost of living crisis that we're all we're in at the moment. And we've brought previously to this board the work of the Social Task Force, which is referenced, but I don't want to take away from the fantastic work that's in this paper. I guess I'm really grateful that we have this piece of work in Shropshire at the moment. I think they highlight the work that's been done in the south of Shropshire to highlight the importance of food insecurity and food poverty is never more important than that is now, and the overlaps and the complexity which is shown in the paper across the system. Again, we're kind of living and breathing out at the moment. I think I particularly didn't want to miss this opportunity to highlight the training that's is being put on, because this is really, really important training that's been developed within Shropshire, with our voluntary sector, with Shropshire Council, with all of our partners, and it's being put on. There's 2 sessions that are being run. We have really limited capacity, so we cannot run lots of bespoke sessions, but everything you need to know will be in these sessions. It will be recorded, and it's for frontline staff, it's for members, it's for volunteers, it's across our whole system. And I think as a board, we absolutely need to endorse that, to push it out and to make sure that everybody accesses that, because it will be useful information for those staff as well as obviously for our households and residents. And I'm just very grateful that for everybody who's put their time to pull that together, and I think we need to highlight, and I think a recommendation would be that we endorse that. And I've said that, and there's another point then, and I know others may want to comment on this, but again, there's a lot in the paper that I don't want to miss, particularly issues around things like stigma that are in the paper. This is an issue that it's going to touch everybody. We know it's going to touch everybody, but it won't touch everybody in the same way. And we'll be bringing updates, and I'll commit to bringing an update to the next board on social task force as well. I think we need to get this really high on the agenda, recognise the impact on individuals, recognise our leadership role within this and the way that we lead this across our communities and our businesses. And so I didn't want to miss the opportunity, I think, to flag that paper.
Absolutely appropriate, Rachel, as well. So I enjoyed really short paper, but brought to life, really straightforward in terms of how it's structured, the economic, the social and community aspects linked to this as well. So we will promote as well the training that you talked about and make sure that that's visible and available, and use our media and comms channels to do that, to support that. Penny.
I just comment too, because I feel that that we often compete with other urban areas for funding, and with that thought that urban areas have the most inequalities and the most poverty, and that's really evident, and it is true. But it's also true that the rural poverty exists significantly in Shropshire as it does in other rural areas. It isn't seen as much, but the work that's being done through Shaping Places, and also the work that was done to secure the funding for Shaping Places as well, really highlighted that. And I just sort of wanted to bring it up again here, because it's really important for us to continue to put those messages when we're bidding for funding, and when we're talking to people about the challenges of delivering services in Shropshire, how health inequalities are massively exacerbated by rurality, and actually we don't know the half of it most of the time.
Equally, really important point. Councillor.
Yeah, thank you. I chair the Rural Services Network, which is an organisation which spends a great deal of its time trying to explain to government the difficulties that are faced by rural communities. It's a hard sell, I have to tell you this. It is a hard sell. But I think government is at last beginning to, or at least the previous administration, we don't quite know what's going to happen going forward, do we? But the government is at last beginning to recognise the fact that sparsity can be just as difficult to cope with as density. Even although density attracts funding and sparsity tends not to. But I think it's very important that we keep hammering this issue home, the fact that rural deprivation is still deprivation. People tend to forget that urban deprivation is one thing, but rural deprivation they don't even recognise. So I think this is, I quite agree, that this is something we've got to keep hammering on. We've got a lot of really quite stalwart communities out there. They know where their sparsity is. They know where their people who need assistance are. I have 10 parish councils myself. I use them all the time as sounding boards for, as it were, the general health of my division. And so I do think it would be very sensible of us to try and make sure that we include these sort of smaller communities in this whole endeavour, because they know what goes on the ground. They could help us hugely, and they'd be willing to do so. So I would just put that down now, because hopefully, as this great endeavour picks up speed, we can get a lot of information and intelligence from them, which we then need to follow up on.
So, Councillor, really well articulated and point well made. I think we've got colleagues on the call involved and in the room in terms of population health and the integration agenda. I think there's a responsibility on us to make sure that we have useful intelligence, as well as then connect with the community, so that we get the voice and we get that understanding of what's going on. We can't tackle health inequalities, and we learned through the COVID vaccination programme, you can't tackle the health inequalities if they're invisible to you and you're not willing to listen and understand how you might engage with communities in a different way. So I think it's a really important point in that. Rachel.
Just a huge thank you. And I think the 4 points that have been raised are really, really important. And again, bring this page to life and add value. I think just as an immediate reaction, one is that I think we perhaps need to relook at the narrative. We sent a narrative letter, we brought it to this board. I think that needs to be updated and given to the new government, particularly. I know we're expecting announcements today, but there will be. They may not include. And probably won't include an impact on people who are on oil, for example. We're still going to have the transport costs, and that's because we're rural. And that will again exasperates, or if that's not the right word, but the impact on food, because people will continue to make choices around food, not eating their home and the food they eat. But actually, we already know we've got huge inequalities in our rural area around food provision. So I think if we refresh that letter, we take an action on the basis of that and resend it. And the other point was around the mapping. One of the bits of work that we are doing is trying to create an index so we can get a little bit more local and use that intelligence to map not only the fuel poverty but with a number of other indicators, because we know this will have an impact on people's health and well-being dramatically. We've already seen some of those figures, and we're trying to create a sensitive index, and it does show a very different pattern across Shropshire. It is not a green index of people doing well. This is quite a worrying picture, and again I think we can commit to bringing that back and sharing that.
And then Rachel, and for me, is how do we share that intelligence with general practice, with community services, with voluntary community sector, in a way that enables us then to have a coordinated impact in those areas where we know with greater risk. I'm as concerned about this winter, given the things that you talked around, the economic impact of the fuel, and everything else that's going on economy-wise, as any previous winter. So our coordinated efforts now, in the run-up to that, I think are really important.
I mean, we are sharing some of that just to reassure the social task force. I think what I would say is that's more important than ever. And we brought last time that there was some challenges around capacity. And there certainly is. We need to be able to put the resource behind this and make sure that information gets out. And we've got a real commitment from the members that are on there. And I didn't say, and I should have said a huge thank you to Emily for pulling this paper together, and all the partners who pulled up together. But I think there's more commitment to bringing making sure we've got members of that. But I would welcome an opportunity to come to, I don't know, partners with the boards like the ICB and others to share this information, and to other forums to make sure it's being presented far and wide. Because as you said, it's not. This is the main issue at the moment.
And sometimes that for me won't be just about the board, it'll be how do we get in front of general practice and front of community service. I'm looking at Angie on the screen in terms of that knowledge with our clinical services, so that we can really think about that. Jackie.
Yeah, I know it's for information. I think there's some really important points that have been mentioned. And I think all the data, all the experience and all the work that's been doing, and the social task force and what's been led by Rachel is fantastic. And what Shropshire's doing to kind of bring people together is wonderful. Colleagues in other counties haven't got this kind of momentum behind. Data is important, community information is important. What we should never forget is the lived experience and that narrative of the people who are living this day to day, and that's where the stigma comes. We read things and you hear what government's saying about, creating work for people. A lot of people who suffer fuel poverty and food insecurity are people who are sick or disabled, who work really hard and can't increase their income, and they're living it every day. I mean, we should look to that experience to listen to how we can help them, rather than create policies where we think we're helping people. And I just want to say that's going to make the biggest difference, I think.
Thank you, Jackie, and again, point really well articulated and well made. Angie.
Thank you, Chair. It's just an offer, really. I think this is an opportunity for us to link into the vaccination programme as it launches this season, where we can actually use this information that has been provided today in all the contexts that we have. So, Rachel, I'll link in with you and Penny to actually take that forward, if that's okay.
Yeah, absolutely. I have to say, I've started to pick up on some of that, because I agree. Every Penny was saying as well, every opportunity, every place we're already at, that's where we need to be pushing out this information. As you said, it's one approach, isn't it? That kind of wrapping it around, we're having contacts, and again, we're taking that approach with our customer services, for example. It's about wrapping all that support, but vaccinations is the prime opportunity. We're out there speaking to some of our hospital, and particularly on the bus, and that inequalities programme. So yeah, I'll take you up on that offer. Thank you, Angie.
Thank you for that. I can't see any other hands or indication people wanting to speak. So Rachel, thank you for bringing that to life, and then for the conversation that's followed on that, actually really useful, and at least 2 or 3 actions for us to pick up from that conversation, and offers in terms of how we connect this work with other pieces of work that are going on, which is the whole purpose of why we sit around the table. It's not just to talk about the papers that are there, but it's about what difference do we make for the communities that we serve and have a responsibility for. So thank you for that. I'm going to move us on then through the agenda, if that's okay with colleagues, and trying to stick to time. So I think we're moving on to agenda item 7. Which was innovative practice digital report. This was deferred from the previous meeting, but is on the agenda properly today. And Chris, you're online, which is very appropriate for a digital report to be updating us this morning. As with the others, I'm assuming the paper's been read by colleagues, but Chris, over to you.
Thank you. Good morning, everybody. Let's hope the technology manages to keep up with me. I do sometimes have a few problems with it, so if you can't hear me at any time, can you just indicate, and I'll fiddle with some of the controls here. You all know who I am then. I'm Customer Services Manager here at Shropshire Council. I hope everybody's had time to read the report. I actually welcome the opportunity to present this because it's a piece of uplifting good news for us all. And I'm happy to answer any questions in a moment, but if I could just make a couple of observations first, please. And the first is that I claim absolutely none of the credit for this piece of work. There's some very positive outcomes in this report, but they're down to the extraordinary effort of the project manager that we took on for this, and that is Andrea Miller. Unfortunately, Andrea can't be with us today, but it's to her sole credit and dogged effort that this has got the positive outcomes for those learners that are reported. It was she that set up the initial pilot, the small learning project. She kept it going through the biggest pandemic in living memory. Not only that, she managed to expand it. She's commissioned the providers and she monitors the outcomes. And when I say monitor, that means pushing and probably a fair bit of cajoling in there as well, just to get the results for these learners. And in that respect, I think the report before me speaks for itself. But there's one observation I would like to make, and it's just to highlight the significance, because this is a relatively small scale project, but I don't think we should lose sight of the unique qualities of this one. And I speak from the heart because I've got very elderly family members myself, and I see firsthand that as a person gets older, the smaller their world tends to become, until unfortunately for very many, it's just the 4 walls that surround them. And it's true to say that any activity that somebody can involve themselves in is always beneficial, but helping people to use the internet, I think, has got a very unique payback, because more than any other medium, the internet can bring that outside world into somebody's home, but it allows them to interact with it in a way that you can't with other media, and at a time for some physically when they just face more and more difficulty with the outside world itself. So in effect, what we're seeing through these learners is that it's turning their 4 walls into 4 windows instead. And for me, it's not just about the transactions. They are a significant part, but it's about the interaction. It's about the contact and the keeping in touch, the not being left behind, and significantly, the not being left out either. And there's also one other final thing that I think we mustn't lose sight of, because I actually believe that the benefits of this project, for the right people, this familiarity with having broadband, the internet, the technology to access it, it's just a short step away from the familiarity with the smart technology that's already out there and marketed. And this is technology that could help people that are otherwise very isolated and very vulnerable for that reason, stay safe and independent in their own homes. And if that were to become the case, then potentially the return on investment for projects like this, which is about just £130 per learner on average, the returns could be very high. So our aspiration for the board to note is that this work should continue, and for that reason we've done project initiation documents for consideration as part of the council's new target operating models going forward, because this piece of work crosses over into so many other areas that the council's interest lies in. So it's a good piece of work. It's some very good outcomes. I think the life stories in the report speak for themselves. And it is, we will deliver on the 500 people that we promised to deliver on by the end of this project at the end of next March. So a good piece of news, and I welcome any questions that members of the board might have.
Thank you, Chris. And you touched on it right at the end for me. I agree. The case studies really brought to life, actually, the facts and figures at the start of the paper. So, the stories and the inspiration in terms of the difference and the impact that's had for me really added value and colour to this paper and to this agenda. So thank you for that. I'd also be grateful if you could, on behalf of the board, pass on our thanks to Andrea for her work and efforts in this regard. That would be appreciated as well. Comments or questions for Chris? Tanya.
Hi Chris, Tanya Miles here. So yeah, great project and a really fantastic report. And those of you who know me well, reading about real people and real stories is a report that I like to read at 9 o'clock in the evening against the other reports that sometimes I have to read. So I think it's a lesson learned for us all, really, that we can start to bring more real life stories forward in our reports. It really brings the reports to life and makes it much more meaningful, I think, when you're a board member. I guess my question is around what next, Chris, and you reference upscaling this, and I guess what that might look like, so the board can kind of put its support to that. And I'm just thinking around broadening this out, that if we can have older adults used to using technology, then things like digital healthcare could be an offer around supporting people to manage their health differently, maybe than rather than going through primary and secondary healthcare, for example.
That's certainly the case at the moment with some of these learners, Tanya. They report that they are already booking GP appointments online. They're getting their prescriptions delivered to them. The whole thing was accelerated by COVID for many, but it also accelerated the isolation. So the size of the project at the moment, it's for 500 learners. And as I said, the return on investment, I think you can only measure it by those individual stories, but at a cost of £130 per person for intensive one-to-one learning, and then the setting up of that peer support. I think it depends on whether the project is accepted going forward, but it does cross over into so many areas that, we've got everything crossed, but we're very hopeful that it is significant, it can make a difference, and for the right people, it can target very specific things. So I don't know what sort of size, but the investment for this group was £80,000. That pays the salaries, the costs, the equipment, and everything involved for 500 people. So multiplying that out, if we're successful, I would want to see that at least doubled over the year, because the capacity is there through the venues that we've got. And if we can find additional places, it's not a huge cost to set up additional venues where people can learn as well.
Thank you for that, Chris. Any other questions or comments? Ben, sorry.
Okay, thank you. Excellent report, Chris. Really heartening to see that. I just wondered, there's two things. One, it's something that I think we need to make sure we're sharing within MPFT, because certainly for service users who would benefit from what you've described. And secondly, as part of that work, did you find that there was also a significant component around sort of deprivation, and how was that kind of dealt with? There's obviously a skills dimension to this, providing that education, but in terms of the nuts and bolts of actually having access to Wi-Fi, mobile phones with data, I know that's something in mental health we often struggle with. People don't have the money to access digital resources, basically.
It does remain a worry, Ben, because obviously as people tighten their belts, broadband may be one of the first things that people do look to. But we know the costs of somebody not being online. The average costs are at least £460 per year. They will be more now. When you weigh that up then against the cost of having broadband fitted, because broadband only without phone lines, relatively cheap. And for what people are actually using this for, it's not a huge speed that's called for. So there are still some good deals out there, I think, but it's persuading people. The learners themselves were a mix. Some of them did have their own IT equipment. They didn't know how to use it, which is why the course started with the very basics of how you switch it on, what to do when something doesn't look right. But there were also others where they wanted to do this and didn't have access. So we've actually provided equipment for them by way of grants. And going forward, if this continues, it will be a mix of the same, because you can't just target people who can afford broadband. Some of the most vulnerable are those that don't have it, potentially frightened by it too. But that's where I draw upon within the experience of my own family, where I've got people that I know would benefit from this. I've been trying to persuade them for a long time to do it, and some now have. So it is a good way of keeping people in touch. And as I said, you know, that is just so good for people's well-being. It does bring down that isolation for them.
Thanks. Just quickly, did you get a sense of the distribution of where those kind of black spots are, where people don't have either the skills or the money to do this work?
From the initial research that we did, yes, we've got data on where people who are excluded are, where they're likely to be as well. And there is an element of rurality in that also. But, you know, with rurality, you're even more isolated potentially. So the data is actually there. We've put everything into a Power BI report, but it does contain the people's details. So we would need to do some work on it to make it available. But what I will do is I'd like members to be updated about the numbers that are coming out of this, and really around the levels of skills increase, because some people are going into this with no knowledge whatsoever, coming out of it with sort of scores against the criteria we're setting of over 80%. So they've learned a great deal in their 10 weeks learning. That I think is useful information, but it should also show in there some of the geography and the demographics too that we're talking about.
You okay with that, Ben?
That's great. I look forward to sort of seeing that when you can share it, Chris.
Okay, thank you.
Thank you, Chris. Any other questions or comments to Chris? Rachel?
I think just a comment really, I think this just highlights the power of kind of early intervention prevention, because actually end up skill, you know, this is where it comes in. It's really got to be an important part of our programme as an organisation, but also as organisations going forward around it, because it shows how a small amount of investment can actually really offset a huge amount of health and wellbeing costs further down the line. So I think that commitment to take, as you said, Chris, take away look at that future funding around the kind of digital work, but also the Shropshire local and that reach out into communities. And this is a really important part of our inequalities plan going forward as well. That digital exclusion you've mentioned, and we picked it up in that plan that will be presented back to Cabinet and as part of the overall ICS inequalities plan. So we're not losing it, but I think it just highlights how important that is and how that investment upstream is really going to make a difference to some of the things that we're seeing downstream. We've highlighted that in so many ways. But what we also need to do is get better at monitoring that and recognising that, I think, as well.
So yeah, really helpful, Richard. So I you know, look, Chris, people have commented positively on the report. I've asked on behalf of the board if we would thank Andrea for the work that she's done in that regard. I think if we think about what Tony highlighted around the potential step in terms of remote monitoring, and we link that to Councillor Motley's views in terms of rurality and the isolation that happens in those communities, there's a clear link there in terms of how we connect some of this work together to really, again, start to put that support and infrastructure in place in our communities. So the board are asked to recognise the detail in the report, note the contents of it, comment on the innovation and the progress made, which I think we've done, and ask that we carry on with that work going forwards. Thank you, Chris.
Thank you very much. Good morning, everybody.
Thank you. So I'm going to move us on agenda-wise, if that's okay. So I think we're moving on to agenda item 8, which is the severe mental illness and complex need, a qualitative review of service user experience. And I think I'm coming to Rhiannon for this, and Rhiannon, you're online and hopefully you can hear us okay. I'm going to come to you on the basis that people have seen the summary report and gone through the slides, but Rhiannon, over to you.
Hi, thank you for letting me present today. I have got the slides to go through if you're happy for me to share them, or if you want me to just talk through it, I can do.
Can I just check, have people got copies of the slides in front of them, and is everybody okay with the slides? So on that basis, Rhiannon, I think it's better that we see you and you're able to talk to us when we do that, and then whilst people are looking at the slides.
Okay, so I'm Rhiannon, a GP ST2 trainee based in Shropshire. I took on the population health project looking at severe mental illness and complex need. My supervisors were Gordon, Helen, Emma and Penny, and we looked at the Shropshire, Telford and Wrekin area. The first thing to note is that, because I think there's been some discussions about this, is our definition of severe mental illness. So I know there's lots of different definitions. For the purposes of this project, we use quite a broad definition which just referred to any mental, behavioural or emotional disorder that severely limited your ability to partake in daily life, and complex need was referred to just being involved in multiple different services for support for your mental health, physical health and additional needs. So in terms of the project rollout, I won't really go much into that. There were basically an online survey or paper-based survey which you could complete, or I conducted lots of semi-structured interviews, predominantly in the voluntary sector and also via Caxton GP practice. It just means that there's that kind of two sets of results. So the first one being the survey results. So these are people who completed the survey. Overall, we had about 49 responses, predominantly white British females, mostly 50-50 split between service users and carers. So carers were also able to answer this survey. So sort of looking at what thing they would most want help with right now, you can see that the main factors were mental health, physical health and relationship issues. But when asked about sort of how easy or difficult it is to get help for those particular needs, up to 50% nearly describe this as difficult or extremely difficult. When we looked at why that is, some of the core themes that came out was poor understanding of what is available and how to help, long waiting lists, lack of trust and poor communication. Now I've highlighted the poor understanding of what is available and how to help because I think this is a core theme that leads to the emergence of other themes and common things that were said, such as nobody knows who to talk to, feeling like we're being passed around and constantly repeating them myself. And those factors I think are leading to this feeling of lack of trust and poor communication. But I think if that understanding element of what is available and how to help, targeting that element in itself will sort of help alleviate all these other themes that are coming out. So when we sort of look like, what does this look like when this patient group are trying to get help, it sort of felt like they were up against this sort of brick wall that they were all trying to get past in order to get the help that they need. And if they were very sick, they almost bypassed this brick wall and they got a lot of help, and it was generally prescribed very positively. They had interventions, medical support, follow-up, and it was a positive experience, but they had to be very sick in order to get it. And everybody else who's maybe unwell but not extremely sick was sort of bounced around lots of different services without actually getting the help that they felt they needed. And if they did end up being referred eventually to what they needed, they were met with huge waiting lists, which eventually led them to get the help that they need, or in the meantime they get very sick, which would get them the help that they need. So when we look at these sort of services that they're being bounced around, individually, I think the services are great. A lot of the experiences comes from the connections between services. So the ones that were looked at, sort of the voluntary sector, GP services, mental health services, smoking, cessation, alcohol liaison, etc. And the general theme was that the voluntary organisation and GP services got slightly more positive feedback. Mental health services was sort of a broad range of feedback from very positive to less positive, and the crisis emergency services seem to flag up more negative experiences. Now, and that the same was true in terms of how they felt their treatment was tailored to their individual needs. The same trend came up. Now, I just want to highlight here, because I appreciate some of it sounds quite negative, but I think a huge part of people's negative experiences are in part based on almost inappropriate use of those services, particularly for crisis. But we'll focus on the positive themes first. So the things that came out were in particular the voluntary sector, very, very positive, friendly, approachable, caring and supportive. If there was a quick response, consistency in care and smooth information sharing, all sort of led to a much more positive experience with services. In terms of the negative themes that came up, there were service delivery concerns and a general feeling that the service was over capacity with long waiting lists and inappropriate service for their needs at times. There were also some staff concerns flagged up, but I think, again, any negative things relating to staff is in large part connected to a general feeling of there's over capacity, and the frontline staff are almost bearing the brunt of that a bit. And I've also highlighted it in here because I think a lot is done to focus on improving patient experiences, and I never really know how much is done to improve staff experiences at work and what is done to sort of make things better for them, because I do believe that you know, if things were made better for staff, a lot, it would naturally translate to better experiences for patients as well. But inappropriate service for my needs was one of the themes that came up recurrently, and some of the stories to sort of behind that, because are demonstrated in the slides. So when I was thinking about that, it's either because the service is just not there, and I think for some of the patients that was true. So for example, one lady described, if you're a child or an elderly person or disabled, there's lots of help, but there's a whole bunch of us in between that there's not the help that I need. So I can wash, dress and feed myself, but I struggle with my finances or catching public transport because of my mental health concerns. So it was a theme around sort of life skills. There's a gap in life skills for these patients, and that was flagged up again in people who have autism. And there was sort of needs around social skills in particular. So I don't know in the social care system how, whether we are responsible for that, I don't know, but it seemed more of a life skill issue. Another example was somebody was homeless and needed safety, so they called crisis. They were very helpful regarding their mental health concerns, but what they actually said at the end is, I wasn't suicidal, my mental health wasn't the key issue, it's that I needed somewhere, a home and a place to stay and somewhere to feel safe. So you can see that scenario, there's sort of inappropriate use of services there leading to the negative experience. In terms of the semi-structured interviews, we had about 44 discussions. Again, a lot of similar themes came out in terms of particularly long waiting lists and lack of support in between services. So when they're getting their treatment, it's described very positively, but there's that gap in between treatments, and I think that's really where the voluntary sector comes in and is why it's being prescribed more positively. But in terms of the other question we asked is, if you could tell the Health and Wellbeing Board one thing to improve your experience of care for your needs, what would it be? A lot of people said, you know, there was a lot of positives come out and that it's generally amazing, but other themes were more patients, more professional, more access. So I think as a whole, I think there's generally a lot of good happening. That's what I felt from the project. There is a huge amount of good services out there. it's like they're just not connected and streamlined as well as maybe the physical health service is, possibly because it sort of represents an infancy in the development of mental health services comparatively to physical health services maybe. But that there is a lot good happening. It's just pulling it all together. So in terms of the recommendations, the main thing I thought about was just simply making much better use of what we actually have, because it is very good, but we maybe need to sort of bring on board the voluntary sector much more, really integrate them with services and elevate their presence within the health and social care sectors, and then have really a targeted campaign looking at raising awareness of all of these services, both for professionals and for patients, because a key theme was people just don't know what's out there. And I didn't know, as a GP, ST2, I had no idea all of these services were out there because we're just not taught about them. You kind of sort of haphazardly find out about them as scenarios are flagged up. And I think patients are feeling that from us professionally at times. The other thing I looked at was the 111 service. I particularly quite like that because everyone knows 111. It's a bit like 999. It's very easy to remember. But there's a huge proportion of these patients who had additional needs and struggled to find help for these additional needs, such as homelessness, domestic violence, substance misuse, and I just wondered whether that could be incorporated into the 111 service. I don't know, but yeah, those were the key things. But I know I've not got a lot of time, so sorry. I know that was very fast. But
so yeah, listen, really helpful and brought to life the slides. You might expect me to say this as Chief Executive of an Integrated Care Board, but for me, what you articulated is the need for integration, because it's the connectivity of services and not just statutory services, public, voluntary, charity, community sector, faith, religious communities. How do we connect better to reduce the duplication, reduce the overlap, reduce the confusion, to enable local people to navigate our services? Quite often we set, from a statutory perspective, at times we'll set our statutory pathways up in a way that suits the professionals that will deliver them, rather than how do we do that to best meet the needs of the residents that we serve. And we need to really think about that. And when I talk about integration, I talk about it through three lenses, and this links to some of your questions. The three lenses, I think that there's an absolute role here for NHS around integration, which is primary to secondary, tertiary, the pathways that are just the NHS side of things. The second lens for me is physical and mental health. How do we bring those together in a more equitable, fair and transparent, consistent way? And the third lens for me then is the NHS with the broader partnership. So social care, local authorities, voluntary, community sector. So if you look at integration through those three lenses, what you've articulated to me is a bit in all of those three lenses where we can do better and where we can get a better outcome for the residents and for the population that we serve. So thank you for that. So I've got a number of hands that have gone up. So yes, sorry, and then Ben, I'll come to you. I'll come to you next, Ben, if that's okay.
Thanks very much. The point I wanted to make kind of builds on the points you were making, and it was highlighted in Rhiannon's presentation about people who've got co-occurring mental health and substance misuse issues. We, from a public health perspective, obviously funds and commission the substance misuse services, but I think there's more we could do working with MPFT to better meet the needs of people with both mental health and substance misuse issues. We are looking to do a joint strategic needs assessment this year for people who've got substance misuse issues, and I'd be really keen for part of that to really focus on the co-occurring needs, so that then we can get some really good recommendations about what do we need to do to move this forward to best meet those needs. So yeah, that was the point I wanted to raise.
Really helpful, and links to my second and third lens of integration in terms of how we connect those bits. So thank you for that, Ben.
Yeah, thanks, and thanks, Rhiannon. Some interesting observations there, and certainly kind of reinforces, I think, some of the things we kind of know fairly well in mental health services. And I guess just to provide some assurance really that things are happening. We are moving towards some quite significant changes in mental health through the community mental health transformation, significant investment into the voluntary sector to pay for things like financial wellbeing services, probably lifestyle services, and some of the other things which we know need to wrap around service users to help them recover and live well in the community. So those things are happening. There's other elements of that as well in terms of better integration with primary care. We're moving to an MDT model in Shropshire where we'll have mental health practitioners based in PCNs. There'll be an MDT to kind of improve that kind of gateway to care, and our access service is also being completely redesigned through the transformation. We're moving to an integrated care record to improve that sharing of information. So that there's an awful lot going on, I guess, is what I'm trying to say. And it's helpful to kind of highlight these issues. I'd also suggest it might be quite useful to talk to our teams about that as well. So you're kind of getting both sides of the coin, really. But I don't disagree with anything particularly which is in that report. I think you highlight some really valid issues, and there's a long way to go. We know that there's a lot to do, basically.
So Ben, from that then, could I just pick up that I think it probably make an awful lot of sense for Rhiannon, the work that you've done to feed through into the structures that we've got in place, and then in terms of some of those conversations around the transformation programme that's in place across the mental health, across our mental health services, and connect those two bits of the conversation. So if nothing else from today's conversation, I think there's absolutely a better connection between some of this work and some of the structures that we've already got in place and some of the transformation that's already happening. So if we could pick that up as an action, that would be really helpful, please. Jackie, you indicated that you wanted to speak. I've got lots of hands up now, so I'll try and do this in order and remember.
Yeah, I think it's great. Thank you. Elevate and integrate the voluntary organisations into health and social care sectors. I think the VCSA, the voluntary sector, whatever, is quite integrated within adult social care and Shropshire Council and things. What we constantly battle against is within our health partners, and I'll take on that action and plot. I've been on meetings, transformation meetings, where health partners have no idea about the voluntary sector in Shropshire and what we provide and what we do. We get invited to partnership meetings or we get talked to, but there's no real action. And at a time when I know capacity is an issue, is that my voluntary sector partners and certainly the chair of the voluntary sector assembly and of the chief officers group in Telford are struggling all the time to try and get conversations with health partners and to start talking about what's there. So there's commissioning happening one-to-one with the voluntary sector, not with the voluntary sector at all. So to when we hear we're talking with voluntary sector partners today about financial stuff, where's that conversation being had? And it's a challenge really, and a respectful challenge, because I appreciate this is all new. We've got a new ICB, a new ICP, trying to get all of that sorted and still carry on providing services is difficult. And you know, if I can from the Health and Wellbeing Board today take up that challenge with you and with the chair of the assembly to make sure that the voluntary sector voice, we know what's provided out there. Come talk to us and we can tell you when you start commissioning services, come talk to us, don't just do it one-to-one. There are a lot of services out there that can help you. You know, thank you for this. I think it's a great report, but there's a challenge out there about how we do this with our health partners.
So really articulate, Jackie, and I'm looking at colleagues on the screen because you've got MPFT, you've got Shropshire Community Trust, you've got SAF, and you've got myself sitting here for the Integrated Care Board. So I think your challenge resonated, has landed. I've heard that clearly. I think health colleagues have heard that clearly. If you won't have heard me speak, but when I will talk about the NHS needing to have a humility in this space and to come and think we don't always get it right in that regard and need to learn and understand how we can do that differently. I guess the bit I would say back to you would be help us to know which arenas we would be better placed in to have the conversations, rather than thinking we know best and we'll do it by, we'll put an event on. Because I think we need to do more to reach out and engage differently, rather than say, we'll run something over here, please can you come to it and we're going to tell you how it's going to be. And I think that's something that I'm certainly talking to my organisation about is I expect us to have a humility and a learning view of a way to engage with communities needs to be different than how we've done it in the past. So I've got a lot of hands. So I'm going to do Angie, then Penny, then Ben, is your hand still up? That's come back in again. Yeah. So Angie first.
Can you do me last? So I think David had his hand up.
Okay. Yeah. I've got fighting people to be last now. So okay, it's a different approach from Cherry. Angie.
Thank you, Chair. And Councillor, I absolutely agree that we need to think better on how we actually engage. And as the SRO for the local care programme, which is a transformation programme within Shropshire, Telford and Wrekin, one of the things that we are actually recognising is the need for us to engage with the voluntary sector and thinking how we do it differently. One of the pieces of work linking to the JSNA and all of that is about how we map services that are local, which are broader than just health, because you're absolutely right, we don't always know what's out there and we actually need to get to that point. So based on Rhiannon's point that's coming through very loudly from a service user point of view, we need to be getting better at this. The only other thing I was thinking about is as you were talking, Rhiannon, is about the high intensity service user scheme that I think is about to launch very soon, Simon, in October. I think your work would be really helpful for whoever's awarded that contract to be part of that conversation, because that's about how they connect and actually interconnect going forward. So I think the connections are coming. We've just got to get better at them. And as a new ICB coming together, this is where this is really powerful. So that's my comment, Simon.
Thanks, Angie, and that definitely plays to the third lens in terms of integration I've articulated. Ben, David, then I'll come to Penny.
And Rhiannon.
Rhiannon. Oh yeah, sorry. Ben.
Okay, so just quickly, kind of in response to Jackie's comments, as fair cop, I think there's a lot of work to do there in terms of that relationship with the voluntary sector. Just to say, Landau have been the kind of point of contact, and Sonia Roberts, who is sort of deputised for you at this meeting, is been the person we've been kind of working through with that work. So maybe there's a conversation just to pick up there around how that's kind of moving forward, because it feels like there's been a little bit of a disconnect there.
Massively. Sorry. Yes, I would appreciate that. Thank you.
And Jackie, use the Health and Wellbeing Board to hold us to account in the right way. So
can we use that as an action then? You'll come back and
I will
update us on how
just
the
conversation.
We're going to have this conversation would be really helpful for us as board members to understand
what happens next.
What happens next.
Yeah, no,
thank you.
Okay, David, then Rhiannon, and then I'm going to move us on.
Yeah, thanks, Chair. Yeah, I fully agree with what Jackie said, but just to flag, I mean, obviously, local authority has been under tremendous budgetary pressure since 2010. We know the reason for that, and they've traditionally been the traditional funder of local voluntary organisations, and their ability to do that has been stretched and is continuing to be stretched. But you know, we know COVID's had a massive impact on local on voluntary organisations' finances, and a large number have gone out of business. And the NCVO, National Council of Voluntary Organisations, our national voices have both published research in the last few weeks, basically saying the cost of living crisis and the energy price crisis is going to force more voluntary organisations out of business. So, you know, fully agree, elevate and integrate, but you need to bear in mind some of them won't be around this time next year unless the system as a whole comes together to ensure they're going to be there.
Thank you, David. Rhiannon, then Penny, and then we'll move on.
Hi, sorry, yeah, I was just thinking about what I can't remember everyone's names, that the lady said before about the main barrier being between voluntary sector and the healthcare sector. I really get that. I feel that myself, because I was so unknowledgeable about all of these services. But in terms of raising awareness, I did think one possible way of doing it is maybe having the main voluntary sectors locally on GP screensavers at work, not a flyer or poster or another meeting, but when I go into work, I log onto my computer every day, on and off multiple times a day. If I saw it visually there, oh, do you remember there's this and this service around you in the voluntary sector, it could potentially be quite a really cheap way to raise a lot of awareness quite quickly. I think I would find that helpful. Flyers would just get put in a drawer, meetings, things get forgotten about, but if every day you sat and you saw that, I think that might work, but that was it.
Penny.
Thank you. Just on that note, if I can pick that up, there's also social prescribing, and social prescribing in each of the GP practices have that wealth of knowledge of what's going on in those communities, as do the community care coordinators. So there's, for GPs, I think, trying to make it really easy. You can just think, right, refer to the social prescriber or the care coordinator, and they have access to that. So there's that element as well. I just wanted to say also on awareness raising, there is an event on the 10th of October, which is at the Abbey in Shrewsbury, which will have all kinds of voluntary sector organisations there as a kind of a marketplace for all of our staff from everywhere to go and have a look at and see what all those organisations are doing and those connections between those organisations. So more information will come out about that. I also just wanted to say thank you very much to Rhiannon, because this was the last this is for Rhiannon has been our Population Health Fellow. It was a competitive process that Rhiannon went through a year ago to become our Population Health Fellow for serious mental illness and complex need. And she's done a really fantastic job of getting under the skin of that and doing this work for us. It's part of a national programme that's funded by Health Education England. And as part of it, Rhiannon has been taking part in workshops around population health, around what that means, around how to analyse population health and get under the skin of it. And a big component of it for a lot of areas, because I've been involved in sort of the programme along the way, is a lot of other health fellows have done this qualitative research, because not just Shropshire but other areas have recognised that patient feedback or that people feedback, how important that is to have that qualitative understanding of what's really going on for people and what are their experiences. And Jackie's already talked about that today. It's like that personal experience, and you really understand what it's like. So I just wanted to say a very big thank you to Rhiannon, because I feel like this gives us something really good to kind of, and I know it's a little bit uncomfortable and not necessarily, you know, it's the humility you talked about. You don't necessarily want to hear about things, but it just gives us a really good launch pad to say, okay, we have this now, we can really do something about it. How are we going to improve that working and around that integration and around those conversations? I suppose my job being partnerships, I'd really like to be involved as well going forward then, and thinking about the voluntary sector as well, and just bringing in the work that we are doing and making sure that everybody knows about all of that already. So thank you very much, Rhiannon.
So really helpful and a great conversation, Rhiannon. Not that you need feedback on the presentation and the piece of work, but the lively debate and the conversation that's ensued, I think, is the best feedback you can probably get in that regard, in terms of what that's triggered around the board with colleagues. So thank you for that, and thank you for coming this morning and presenting. So I think we've agreed the actions that come out of that report anyway, as we've been going through. Was there anything else that you wanted to pick up particularly? Because the recommendations were make better use of, and I think we've talked about how we do that integration piece and the work that needs to go around there, building on the things, Penny, that you pulled together at the end. There's the broadening NHS 111 advice. We'll have that. I'm happy to pick that up as a conversation with NHS 111, but there will be a national piece around that. And the piece around dramatically increase the workforce. I don't think that's our board's remit to be able to dramatically increase the workforce. But I do think the conversation that Ben and Angie and Penny followed on with, and saying how do we build this into the work that's already happening in terms of the transformation agenda, I would ask that that gets picked up through that route, if that's okay. Yeah, okay, thank you. So thank you for that. I'm a little bit behind in terms of time, but I wanted that agenda item to have the airing and have the conversation that ensued. I'm moving us on to the CARN review, making smoking obsolete. Paper. The paper is in your pack. I assume people have read the paper. Victoria, you're very welcome. You were sitting there quietly behind, but now come to the front. So if you can work on the principle that people have read the paper, but really good if you can just bring that to life for us all. Thank you. And a brief introduction in terms of who you are as well.
Yeah, absolutely. I'm just not sure how to use the technology. Press this button. Just checking everyone can hear me online. Brilliant, thank you very much. I'm also going to share some slides, if that's okay. Bear with me. Oh, this is Brilliant. So hello to everyone in the room and hello to everyone online. So my name is Victoria Sanford. I'm a public health trainee. I started at Shropshire Council about 5 weeks ago, and I'm currently working with the health improvement team under the supervision of Bernie Lee, public health consultant, and also Sue Lloyd, who I can see is on the call. So I'm going to talk to you today about the Khan review and really the report that has been convened around that in terms of what the implications are for Shropshire. So presumably you all read the report, or at least the executive summary. So I'm really just going to take some summary points, really just to talk about the kind of main highlights and what this report that was really on a national scale really means for us in Shropshire. So just to start by setting the context for us about smoking, so we know that smoking is the single biggest cause of illness and death nationally. Again, just to feed in some important numbers around that, we know that 6 million people in the UK are still smoking, so that's about 14%. Just to say very briefly that in the report it said 6.9 million in England, just to say it's actually 6.9 across the UK. So that's obviously come down from the really high levels that there were in the 70s and 80s, for example. That's coming down as a result mainly because of tobacco control, but that is still significant given that it is the single biggest cause of illness and death. Thinking about deaths attributable to smoking, as you can see, over 190,000 a year, and about 500,000 hospital admissions per year. So if we think about what does that number mean, if we put it into comparison with other causes of hospital admission, something like substance misuse, so the mental and behavioural disorders or the poisoning as a result of substance misuse, contributes to about 24,000 hospital admissions a year, and something like obesity about 1 million if we think about primary and secondary diagnoses. So just to put that into context of what those figures mean. Let's now think about Shropshire and what this means for Shropshire and what the smoking burden is in Shropshire and how this compares to the national average, and indeed how it compares to our 15 what we call nearest neighbours, so those local authorities that are most similar to Shropshire in terms of various characteristics related to geography, demography. So as we can see, the smoking prevalence in Shropshire is not dissimilar from what it is nationally. We can see that things like smoking attributable mortality, so mortality in general, but also mortality from COPD, so chronic obstructive pulmonary disorder, very related to smoking, and also to lung cancer, slightly lower than the national average, although around middling for where we need to be compared to other local authorities that are similar. We can see here the hospital admissions are higher than the national average in Shropshire, and quite high on the list compared to other local authorities, so Shropshire not performing as well as we might like. I think I don't know why that slide hasn't moved on. Not sure why that hasn't moved on the slide.
I'll try and share mine.
Let's see if I can.
I'll try and share as well, Rhiannon, see if that helps.
Apologies, not quite sure why that's stopped sharing. We're just about to get on to the juicy bit. Shall I stop sharing then?
Yeah, I'll see if I can get yours working.
Or I can just try again.
Yeah, try again, and then if not, I will try and share it for you.
You would think being here in person we might be able to avoid technical glitches, but unfortunately not. Apologies. That doesn't seem to be working.
Let me give it a go.
Okay, I'll stop sharing. So what I'll probably do is speak to what the issue is on the slides as we are just waiting to get them up. So if it goes on to slide 4, if that's okay, Val.
Yeah.
I think the main summary for this slide, really, I think you've got the numbers there, we don't need to go through them, and you've probably read them. I think the summary really here is that whereas smoking in Shropshire is around similar to what it is nationally. We can see here that for some particular groups it's a health inequality issue. Given that reducing health inequalities is a main point in our Shropshire plan, I think this is particularly important for us. So what we can see here is that there are certain groups, so pregnant people within Shropshire, those who are working within routine and manual occupations, often associated with being the most deprived or low income in society, and also people who are dealing with mental health problems, so people who are living with anxiety and depression, and also those who have severe opiate misuse problems. We can see that the smoking prevalence in those particular groups is particularly high in Shropshire and higher than the national average. So what this really tells us is that there are some particular at-risk groups in Shropshire who are really being affected by the health inequalities related to smoking. Would you mind? Oh, thank you. So just to think about the costs here and what smoking really costs us as society, moving more, thinking about wider costs, not just to health and social care, but also to things like productivity, loss of earnings, loss of employment. We can see here that £17 billion a year is the cost of smoking to wider society, and that's about 2.6 billion to the NHS, and that's from 2015. In the graph below, you can see here the numbers for Shropshire specifically. So we can see that productivity, we are losing about 66 million a year related to smoking, healthcare about 16, social care about 8, and fire costs related to smoking related fires about 1.3. That really, if you think about the equivalent to what, so if you think about the comparative figure of about 16 million that we are spending at the health and wellbeing budget within Shropshire Council. So it really just puts into perspective that this is a significant issue for Shropshire. Next slide, thank you. So now coming into the Khan review itself, and then we'll think about what this really means for Shropshire, just given that we've set the scene now for where we are with smoking nationally and locally. The Khan review was an independent review that was published earlier this year in June, and it was really an independent review of the Smoke-Free 2030 ambition, which was set out by government in 2019 to reduce smoking rates in England by 5% by 2030. I think really the main headline here from this report is that we are going to miss that target by at least 7 years. And for those who are most deprived in society, we won't reach that target until 2044. So way off target, particularly for those groups that I mentioned before who are particularly affected by smoking related health inequalities. As a result of this review, Dr. Khan put together 4 main recommendations that really fit into these 4 main areas. So the first is investment. We need to invest in the ambition. And actually, Dr. Khan set out a new target to reach 5% by 2035 and make smoking obsolete by 2040. The second was really about reducing the number who start to smoke in the first place, particularly young people, so moving towards prevention. The third is stopping smokers, encouraging and supporting smokers to quit for good. And the fourth is about enabling NHS, again, to move upstream towards prevention, but also to continue its support and providing treatment for those who do want to smoke. Next slide, please. So I don't think we're not going to go through this. This is really just a pictorial illustration of what the review is all about. And I'd just like to draw your attention to the 4 main areas that I've just gone through. But the boxes that are surrounded in a red square, those are what we call critical recommendations. So those are the sort of must do now that Dr. Khan put together that are really the recommendations that will have the most impact in terms of bringing down tackling smoking. So firstly, you can see it's investment, and whilst that is investment at a national level, so things like getting additional funding from government, but also raising money through tax, through levies, industry levies and corporate surcharges. We've also got here, which I think is particularly interesting and quite progressive thinking, is raising the age of tobacco 1 year by 1 year every year. And what that really does, it creates a smoke-free generation, so whereby there is no child who has lived at a time where it was legal for them to actually buy tobacco. The third is about offering vaping as a substitute, and I think this is a particular highlight from the report, the kind of place of vaping as a quick aid, and making sure that we have accurate information for healthcare professionals and for the public about the place of vaping within this narrative, about it being a quick tool rather than a cool tool. And then fourth, it's about the NHS needing to prioritise, again, moving upstream towards prioritising prevention, but also by providing further and more systematic support for people wanting to quit. Next slide, please. Thank you. So what's happening in Shropshire? So thinking about, in light of this report, what can we say about what we're doing in Shropshire to tackle smoking and smoking related inequalities? So this really falls into four main areas. The first is tobacco control, and that's really led by the trading standards colleagues. So the first is there are enforcement activities around illegal tobacco, around sort of disrupting the supply chain of illegal tobacco, and particularly identifying, detecting and preventing the sale to minors. The second kind of area of this is the tobacco dependency treatment programme, and this is really part of the NHS's long-term plan that was set out to where tobacco control was and prevention was set out as a long-term priority for the NHS. So this is being coordinated and led by our NHS partners, and is really based on an opt-out basis, where patients who are at maternity booking, so newly pregnant people who are at maternity booking, or indeed seen in acute hospital, so inpatients, are started on an opt-out basis for behavioural and also nicotine replacement therapy. The expectation is that there will then be a follow-on of 12 weeks of support, which will be coordinated by either local services or by a new pharmacy scheme. So that brings me on to our third point. So there's a new national scheme for community pharmacies to provide that follow-up support for those who have joined the opt-out services whilst they've been in our NHS care. That 12-week post-discharge community support is both behavioural and nicotine replacement therapy. That is a new scheme, and there's a few pharmacies in Shropshire, quite a small number in Shropshire, who have actually signed up to that so far. So that's thinking about the continuity of that initial service that started in hospital. The fourth is what's happening at local authority level. So the dedicated service for smoking cessation was decommissioned in 2019, but there is support and we are in the process of creating that support. So there is support through the social prescribing service that was alluded to in the previous presentations. There is also plans in place to operationalise a new service which is looking at behavioural support cessation for those who have been discharged from mental health inpatient treatment. So those who are those mental health patients who are getting inpatient care, started on smoking cessation and then are discharged into the community. That 12-week support is then we're looking at then offering that through local services. That would only be for behavioural support, and actually the nicotine replacement therapy is provided either at the discretion of the GP or by the patient themselves. So that's what I had to say for the moment, but I'd like to just defer to Rachel if you'd like to add anything to that. Thank you.
Thank you very much. Thank you for pulling that together, and I think it's really important that we bring this to the board's attention, because as you've laid out very clearly the importance of smoking and the impact that that has on health and wellbeing in our population. So just thank you for that. I think this is a really important report. It is a national report, but as you said, we didn't want to shy away from the fact that there's clear recommendations for us locally in Shropshire. Again, I think within the report, there's firstly positively, whilst you know, for me, and if Dr. John Pepper was here, I know he would be flagging up and saying, actually, this is an important issue. We have not got smoking cessation services that are decommissioned. Not shying away from that, because actually what we wanted was a system-wide response, and that's what we're getting. And when we are already, as you said, looking at investment and looking at what more we need to put in to support the system. We have got a system-wide response. We've talked about pharmacies, we've talked about the work we're doing with GPs, and we're working very closely with GPs. Our social prescribing offer that we've put in. Trading standards is a really, really important role, particularly in vaping, and I know the team will tell you a lot about some of the illegal substances that can make their way to our young people. So again, so it is absolutely a really good demonstration of the system response, and as you've said there, we're actually looking at what more investment we need, and we have put some funds aside to do this. And again, it's as a system, where do we need to put the gaps, what's the best for our population, and I think particularly in terms of that behavioural support and making sure we follow through. So I just wanted to highlight that, and I believe, you know, in these meetings we're always open and honest, and we'll be coming again back to members of this board through our structures to make sure that we do that in the right way, and consulting as far as possible with the resources that we've got.
So thank you, Victoria, thank you, Rachel. Councillor.
And just to add to that, just to add to that, the work that the local police have done in supporting, obviously with my connection with the supporting young children in schools in Shropshire, the work that the local police have done with vaping and the team here, it's been outstanding actually, the response. So just to highlight, and shame they're not here today, but hopefully we'll get a message back to them, say thank you.
Ben, then Tanya.
Yeah, great report. Just to acknowledge and say thank you to Rachel and her team for finding that resource to support the discharge of mental health patients. It's been a vital part of providing or creating a pathway for them. And also just to add that from next financial year, I think it's likely that there'll be a smoking cessation offer for all mental health patients in the community as well, which arguably is probably where it should have started anyway. So there's further resource to kind of follow nationally down to a local level to support that.
Thank you, Ben. Tanya.
Yeah, good report. That's a good update there, Ben. Thank you for that. I guess I was a little bit surprised with recommendation 8 about offering vaping as an alternative, and I guess I don't think I've missed it, but I don't think we've yet seen any kind of research paper yet that kind of talks about the impact or the consequences of vaping. And I know that our schools are reporting a real rise in quite young children now vaping in the toilets rather than smoking in the toilets. And I'm really keen for us as a health and wellbeing board to think about what can we do to educate our young people and our adults about vaping and what that can lead to.
Victoria?
Yeah, so I think that's a really important point, and it certainly was a point that was highlighted within the report, and it has created discussion amongst the public health community. I think Public Health England particularly have been very clear that it is not risk-free. Vaping is not risk-free, and you're right in that research is emerging about the potential risks of vaping. And actually, research that we've seen has shown that vaping is about a third as dangerous as smoking. So Dr. Khan in his report actually says 98% as dangerous, which honestly I'm not quite sure where that number comes from. I think it's because there's some research that shows that the chemicals and toxins which are in cigarette smoke, there's about 0.5 to 3% of that present in vaping smoke. So I think that's where that figure comes from. But the research that we've seen so far shows that it's about a third as dangerous. So definitely not risk-free, but definitely much less dangerous than smoking itself. I think the place of vaping really, and I think this is alluded to in the report, is it is a quick tool. It is not a cool tool. And you're right in that there are currently more young people who have ever tried either smoking or vaping. More have ever tried vaping than smoking currently. So there is that success in that we are bringing down the numbers who are smoking tobacco quite significantly, but you're right, and that's where vaping comes in. I think what is very, very important to say is that vaping is a very good quick tool. So there's lots of research that shows that for smokers, and the majority of people who vape are smokers who are in a quit attempt, that actually smoking is a very cost-effective way of quitting smoking when used in combination with things like behavioural support. And it's potentially more cost-effective for people, about a fifth as expensive as other measures for quitting smoking. So I think that's why Public Health England's messaging really is around it being useful for quitting, with it not being risk-free completely.
Rachel?
Yeah, and I think Tanya's point is how we get those messages across, and that's where I alluded to the work of training standards are critical in this, because what we are seeing is a rise in the vaping being made attractive to younger people who are using it to start as an alternative to smoke, not to help them quit. And it's that messaging that we need to do much more work on, but also our training standards team are cracking down, because not all of them have those levels of nicotine, and they are being presented in a way in various flavours, and you can imagine that's targeting a particular audience. So that's why their work is critical, and that messaging is critical, but because we don't want to lose this as an important quit tool, because we need to get those numbers down, but equally we don't want to bring children and young people at risk. So it's a messaging.
Just very quickly to say that there is some national guidance being developed around youth vaping by the Faculty of Public Health and a range of the national bodies, and I think that should be coming out soon, and that will help us make sure we get those consistent messages out across the system, so we're all, you know, talking the same language around this issue.
Helpful, thank you. Okay, so Victoria, thank you for that. Really appreciate that. In the report, the board are asked to note the finding the recommendations made in the review and the significant health, social and economic benefits associated with making smoking obsolete. I think that was really clear. We've had that conversation. The board is asked to acknowledge that while the recommendations are nationally focused, the local need for investment in the tobacco control programme and smoking cessation service will need to be reviewed in the light of the report. And I think Rachel's updated in terms of how that's going to be taken forward and what that looks like, and also Ben's updated in terms of what's happening from a mental health provider perspective. And the board are asked to recognise the implications of the recommendation in terms of vaping and the extent to which local smoke-free policy should differentiate between smoking and vaping. I think we've just picked that up in that final part of that conversation with Tanya's absolutely appropriate challenge in there in terms of where the evidence base is and what does that look like, and the update that goes to that. I guess so I think the board acknowledge all three of those and recognise those three. I think the bit we probably need to, the one that we need to add is this needs to come back, doesn't it? So it needs to be on our future work plan, and we need to be having a conversation around what progress are we making, where do those numbers on the chart earlier where you put us against the 15 other similar local authorities, recognising that they don't move on an annual basis a lot, but actually where are we looking at the interventions aligned to those measures, where does that get reported through to, and what does that look like? So we need to just make sure it's on our work plan going forward as a health and wellbeing board. Yeah, you okay with that? Yeah, good, thank you. Okay, thank you very much. I'm going to move us on then, if that's okay. We've got 20 minutes and we've got 2 items left to cover, and I don't want to squeeze the time in terms of those. So we've got the GSNA update and we've got the health protection update. I can absolutely promise you that the chair's update and close will be swift. So we're going to move on to our agenda item 10, which is the GSNA update. I'm initially going to come to Rachel, I think.
Yeah, thank you very much, Chair, and I will keep this brief because I'll assume that everybody's read the papers, but there is a couple of key things in this really that I wanted to highlight. This is obviously the usual report the board receives on the progress around the GSNA. The GSNA is in a number of parts, so we've got the place-based GSNA and we've got kind of direct thematic GSNAs, and we've already mentioned one in the meeting today that will be coming shortly, which is the drug and alcohol needs assessment work that we need to do, but we need to do that by November, so that's coming up in the future, and I'll come back to Andy in a moment around the pharmaceutical needs assessment. But just to update in terms of our place-based GSNA, so the board would be well aware that we started this process and agreed to it back in 2019, and then a little the November time to December, and then we got a little pandemic that got in the way of our progress around that. So what you'll see from this report, I hope, is that we are moving forward, and what's attached is, first of all, our web-based tool, which is kind of baseline. That's the fundamental basis that we'll be putting that information together in a web-based profile that people and public will be able to access, and we hope to launch that later in the year. But the screenshots to share with you the progress that's been made. Those will be added to as we go along, as we develop thematic GSNAs and draw that data into that web-based tool, and it will become a really important part and a fundamental basis for our population health management as well going forward. The next bit of that then for us is the place-based GSNAs, and the importance of the place-based GSNAs is taking that information that's in those web-based tools and additional information that we've got from research and information and from our various needs assessments, but actually, and we've heard a lot about that today, bringing in our stakeholder voice, bringing in our patients' voice and asking them what are the big issues around their health and wellbeing that matter to them, and listening to those realities that are coming from our communities. And so that is the piece of work that we've started. With the piece of work in Highly, that engagement exercise is complete pretty much now in terms of those initial questionnaires, speaking to the public, speaking to key stakeholders, and there's some themes emerging. We're also undertaking that in Oswestry and St Martin's at the moment, and then we're rolling that out across the other areas, and we'll be capturing that data, because that data, I think, as we've said, is absolutely fundamentally important, and we need to build that in, not just taking the data that we've got, but this is how we interpret it. The next stage, and we're doing this in Highly on Monday, we've got a stakeholder event, so we're collating all of that information together, and we're going back to some of our key stakeholders to develop the recommendations based on that. Does this make sense to you? Are these the key themes that are emerging? What are the recommendations and actions we need to take going forward? And as we roll that out across the county, we'll learn from that and we'll bring that back to the next board meeting. We'll be going in then and doing that in Oswestry and moving around our 18 place plan areas to collate that information. That will collate local information around recommendations, but also recommendations that will sit here, that will come to the Health and Wellbeing Board at a Shropshire level, but also will feed into the integrated care system in terms of where are the key areas that we need to be focusing on the recommendations. So that is moving, and I think by the next board we'll commit to bringing an update to the next board, and we can update you on the progress of both the web-based tool, but also how those place plan needs assessments are being moved forward. And it comes back to Nicola's early point around the ICP. The GSNA is a fundamental building block of this in terms of the ICP strategy, our health and wellbeing strategy. It's the source of evidence and information from which everything needs to flow. And we've updated it back in 2019 for the strategy, and updated it again. We're constantly looking to refresh this, and that links into our population health management approach within the ICS. So hopefully you can see it's all dovetailing, and it's a really, really important piece of work, and we'll bring a further update. So whilst we're doing all that, we're also having to tackle theme-based needs assessments that need to be delivered to support the Commission with key services. And one of our statutory responsibilities is, as you all know, is the pharmacy needs assessment, which was handed to us as we set up Health and Wellbeing Boards, and NHS England kindly asked that local authorities, local health partners through the Health and Wellbeing Board deliver these needs assessments. They are weighty. They are set out in regulations, and we have to follow a particular process. So I just need to head off for that because it is a big document, which Andy is going to give us just a very brief flavour of some of the summary within that. And it does need to go out for consultation. It is out for consultation at the moment, but we thought it was pertinent and a good time to bring it to the Health and Wellbeing Board. We're hoping to publish it in line with the statutory deadline of the 1st of October. So we've got a very tight turnaround. So I just wanted to give you that, and we are producing an executive summary for those who do not like to read several hundred pages of needs assessment. So I'm going to hand over to Andy and just ask Andy. I think everyone's had the slides, so I think Andy's still on the screen.
Yeah.
So Andy, I think people have had the slides, so and given time, if you can just pull out some of the key points. Thanks to Andy and the team for a huge amount of work that's gone into this, because it doesn't just happen overnight. So the other point just to make is actually this has been done, we've done this collectively across Shropshire Health and Wellbeing, and I'm really pleased that we've got so many joint bits of work that are going on today that have been highlighted. So I'm going to stop.
And just quick before Andy comes in on the pharmaceutical needs assessment, it's not yet sitting with integrated care boards, but the delegation of community pharmacy and the independent contractors is happening over a period of time from NHS England. So a strong pharmaceutical needs assessment will be fundamental integral to commission-based decisions around future pharmacy provision. So getting this right now for our system to enable those decisions to be taken as part of the system going forward, so that local context will be really key. So I looked at this with some interest, given what I know what's coming on my agenda next year. Andy, sorry.
Okay, good morning everybody again. I'll just run through, I won't run through the slides because there's quite a lot of them. I'll just run through a couple of, well, more than a couple, a few points to sort of bring out, which affects the recommendations really. So it's just some sort of underpinning evidence numbers. So at the moment there are 47 pharmacies in Shropshire LA area. That's gone down slightly from the last time 3 years ago. Our resident questionnaire, we had 421 responders, which is slightly smaller than we would have really wished for, and we're conscious that there is a slight bias in there towards ladies. It's sort of roughly 2/3 ladies, 1/3 men, as they identify themselves. And it's also slightly skewed towards more affluent socio-economic groups, towards the A, B categories. So again, something to be aware of. So what did these people say? There was very variable awareness of the services that pharmacists can offer. So it went down from 0 right up to 86% for prescription pickups. And there's a huge range of services in there, so very variable. Travel to the preferred pharmacy and parking was well received. That's in the 80-odd%, so that sort of is good news. Opening hours, most people were satisfied with, so 88% for weekdays, slightly lower for weekends. Again, that's going to come up in the recommendations. One point that was raised was consultations with pharmacists. So this was one of the lowest satisfactory ratings at 59%. So lots of people commented that they would prefer consultations to be in a private setting with their pharmacist, although most people, 9 out of 10 people, were very happy to have a consultation with a pharmacist. 2/3 of people said that they would be prepared to go and talk to their pharmacist about a service that they weren't currently aware of. So again, good potential here for pharmacists to pick up activity. So that's what the people were saying, the responders, the 421 responders. The pharmacists themselves were saying very variable in the services that they offered. So anywhere between 1 and 42 of the different 47 pharmacists offered services and a mix of services. And generally somewhere between 60 and 70% of the pharmacies would be willing to offer a wider range of services. And again, the details in the report of exactly which services. So I'm being rather sort of broad skimming over there. There were 3 pharmacies that came back and said they offered 100 hours a week. That's slightly lower than we would expect if we compared ourselves to our nearest peers. And then the last key point was the provision. Within England, we've roughly got 1 pharmacy to 4,800 residents. In Shropshire, that's 1 pharmacy to 6,800 residents, so very roughly a third less. And last pharmacy needs assessment, it was 1 pharmacy to 5,800 residents. So effectively, I'm saying we're getting a lower provision now than we used to have 3 years ago, and we've got a lower provision than to England. There is one very big caveat there. Because we're quite a rural county, we've got a lot of GP dispensing practices compared to other LAs. So if we put in the GP dispensing practices, and there are 17 in Shropshire, that brings the ratio down to one community practice or dispensing practices to every 4,800 residents. So that brings us exactly level with the England, in round figures, to the England averages. Perhaps one point to note is that dispensing practices tend to have more restricted opening hours than a community pharmacy, so it might be camouflaging it a little bit there. So perhaps that needs a little bit further discussion. The recommendations then that I bring out, so it was identified from the full report that basically South Shropshire appears to have a lower offer for pharmacies, and that might be something to investigate and see if we could get some more provision in the south of the county. And that was a similar message to last time. Sunday opening is a consistent message that comes across, that we could perhaps have more provision with Sunday opening, and again, particularly in the south of the county. Increasing communications between the different parts of the system, what services the pharmacies offer, where they're available, when they're available, etc. Raising awareness of the different services that pharmacies offer. So that was, like I said in my preamble, very, very variable depending on which service you're looking at in particular. It's felt that there is an insufficient pharmacy provision within the county, and again, particularly in the south. And then something else to think about was the growth of the population in the future. We know that there's somewhere just under short of 29,000 extra houses planned to be built or being built in the county in the next couple of years, and also that Shropshire has an ageing population which is ageing faster than the England average. So just to put some meat on the bones there, between 2000 and 2020, the median age in England went up from 38 to 41. In Shropshire, it went up from 41 to 48. So we're already older than the general population in England, and we're getting older faster. So why is that important? I think everybody's aware that older populations tend to require a higher level of input from the healthcare system. So I think that's one reason why the ageing and growing population combined with a slightly shrinking provision means that we might be in some areas where there's not enough provision within the county. That's my very, very brief summary, and I'll try and answer any questions if anybody's got some.
Thanks, Andy. Rachel?
No, just to say thank you, Andy, for that. And I think the recommendations obviously is what we want to draw people's attention to, particularly to make sure that they're the right recommendations as we're out for consultation. I think it highlights to me these needs assessments always do the invaluable role that pharmacies play as part of our health and care system. I think in the last presentation when we talked about provision and smoking, it illustrates that, but also through the pandemic. And I think that the pharmacy needs assessment always strikes me as an opportunity to remind people of what provision we do have, but what more we need to do, and also recognising that there is some gaps and we do absolutely need to look into the future. And again, rural has come up again. So some common themes and some really important issues for us to address, and just welcome the board's comments, but also would like to encourage people to fill in the consultation to make sure we get the right response.
Thank you, Rachel. Angie?
Trying to get off mute as you always do. Thank you. I've obviously got a very good interest in this because pharmacies are one of the vehicles that deliver some of the vaccination programme. And just to say, in this round going into the autumn campaign, of the 47 in Shropshire, we've now gone up to 24 pharmacies that will be delivering part of the vaccine programme. So that's a significant jump across Shropshire, Telford and Wrekin from what we had. What's really interesting, I think would be helpful, Rachel, is the mapping that we've done on the travel times to those pharmacies might be helpful for part of this consultation. You know, the geographical spread map, it just gives a different lens for what people are looking at. So the recommendation about opening more times in South Shropshire, there might be an alternative provision in South Shropshire, i.e. not in a community pharmacy, it might be inside Asda, for instance, or something like that. It's whether those connections have been made is one of the questions I'd ask.
Yeah, and Andy might want to come in more, but when we're looking at pharmacies, it's wherever they're located in terms of some of that mapping. But I think, yeah, the point about the travel mapping is really, really important, particularly in some of the work we're doing. I think we can use that more widely across some of the other service provision.
Okay, thank you. Councillor?
Thank you very much. I'm just wondering, this is a very interesting report. Thank you for it. I'm just wondering, though, just thinking about particularly the south of the county, there has been over the last months desperate shortages of pharmacists, and a lot of our pharmacists seem to travel into the county from a long way away. I mean, I'm talking Wolverhampton to South Shropshire, which is quite a step really. And I'm just wondering whether, I know that sometimes there's been a shortage of drugs as well, and these are all issues totally outside our control. I'm sure, because I suspect it was all to do with the, you know, things being held up at the docks, etc., etc., etc. But certainly, in one of our market towns, Ludlow, the provision of pharmacists at one stage was so patchy that of the 4 chemists that we have with pharmacy services, sometimes 2 or 3 would be able to provide no drugs. You know, because there was no pharmacist. They couldn't provide prescriptions. So I'm just wondering whether there is a sense that we are short of them, that we're not growing our own, and if there's any way that we can start to encourage becoming a pharmacist as a, you know, as a really good professional move, and whether anybody is sensing that there are problems generally with the supply of pharmacists.
Sure, people want to reply. There's a couple of points in there for me, Councillor, I would respond to is, firstly, I think the shortage of drugs, you're spot on. That was about supply chain and lots of things that happened around that. I think the workforce issue around pharmacy sits alongside all of the other NHS workforce challenges. I think in terms of how many do we need, how many can we train, over what time period. I think the people board that sits across Shropshire, Telford and Wrekin is really focused on how do we retain the staff that we've got, how do we develop staff that come from our own local area and want to stay in that area. So how do we work with further education, higher education in terms of the training programmes that do that? And then how do we make ourselves an attractive place to work so that people want to come in and work in this area? So I think we've got to go across all 3 of those areas of that agenda and the people agenda to get into that space. It links also to the point I said earlier that up until April of next year, community pharmacy and community pharmacy responsibility sat with NHS England, so it wasn't the responsibility within Shropshire, Telford and Wrekin. However, from April next year, then the Integrated Care Board will start to take responsibility for community pharmacy, as it will do in terms of some of the other independent contractors as well. So I think there's an opportunity there for us to be thinking about how we want to work locally, both with our current community pharmacies, but also what does the future start to look like. Hence my point of the pharmaceutical needs assessment is a key driver in that, looking at our workforce model and looking at how we provide services and commission services going forward. Angie?
Just to say that I am aware that pharmacists are on the national list as a red list, so they are in what they call endangered, from want of a better term, from a workforce perspective. So I know that nationally the national teams are looking at how to increase pharmacy students placements across the whole country, so I think we're not unique in that space.
Good. Okay, so look, really useful report. Again, the slides really interesting. Recommendations get to the point and get to some of the crunchy bits of what are our challenges and what can we be doing differently and what does that look like. I think in terms of the web-based needs assessment, important update in terms of that as well. It's a minor thing from me. I don't think it's so I think you haven't done it, but I absolutely fully support the life cycle approach. We've got a slight issue where it's starting well, living well, aging well and dying well, but you've not gone down that route because you should be able to die well at every age in the life cycle. But you've not put that in that route because there's always a risk of it. It looks like you only die well when you've got old, and that's not the case. We should be able to support that across the life cycle. So I was pleased that that wasn't the route that had gone down across our area here. The board are asked to note the contents of the report, the work programme that's in place and the timescales. And I just want to say thank you to colleagues that are working on this, because a lot of work in here, a lot of detail is really, really useful and really interesting. Okay, I'm going to move us on then, if that's okay. So thank you for that. Thank you, Rachel. Thank you, Andy. Thank you too. I'm moving to the health protection update.
Thank you, Chair. I will keep this short as I'm very aware of time.
My class chairing, Sue, rather than anything else.
Absolutely not. It's been a fascinating meeting. So we haven't had a Health Protection Board meeting since the last meeting because of summer, and therefore the detail of this report is very limited. There will be a more detailed report next time. So the important issues from this are the system in terms of COVID seems to be open. Our numbers of cases of COVID in care homes are reducing. So at the moment, we currently have 90% of our care homes open, and I'm trusting, and the feedback I'm getting is that that is enabling us to keep the system moving. So that is really important. The other major point is our health protection strategy, because going forward, we want to ensure that we've got systems in place to protect our populations. We have written a health protection strategy. It's gone out for consultation. I can see Angie's nodding, so she will have seen it. It's gone to national level to our UK HSA colleagues. It's gone across the system to our health colleagues and other colleagues who are engaged with the Health Protection Board, and we have sent it to those more widely who are engaged with health protection. Happy to send it out to anyone on the Health and Wellbeing Board who would like to comment. We are collating comments currently. The next meeting of the Health Protection Board is the 16th of September, and we're planning to take the comments to that board. So if anyone could let me know today, I would appreciate it, and I will send it after the meeting. Other than that, we will bring the health protection strategy to you once it is complete. So thank you, Chair. Thank you.
Thank you, Sue. Any questions or comments for Sue? Rachel, anything you want to add to
No, I think Sue's highlighted the main point being the strategy and the systems that we're putting in place to make sure as one system, Structured Health and Wellbeing, we respond to health protection in a coordinated way and build on all the learning from COVID. So I think, again, if anyone has got an interest in that and hasn't already commented, I've just asked them to be able to do that.
Okay, thank you. I mean, Sue, really helpful, but equally what you're saying is at the next meeting, there will have been the meeting of the Health Protection Board, so there'll be a bigger update then that will include the screening and INS update and the detail that sits behind some of those areas.
Absolutely.
Yeah, okay, thank you for that. I can't see any hands or comments or questions. So thank you for that. The report is noted and will be on the agenda going forward as well. Thank you. So final item on the agenda is the chair's update and close. I promised that would be brief. So there's 2-3 things I just want to update on. Yeah. The air quality report was scheduled for this meeting, has been deferred to the next agenda, and that's the case also for the safeguarding annual report, which colleagues will be aware comes to the board annually, so that'll come to the next month's meeting. The Shropshire Healthy Weight Strategy consultation has now gone live. That opened on the 5th of September and closes on the 31st of October. Board members will have received an update about that. The public and stakeholder survey can also be found on the Get Involved section on the front page of the council website. So would ask colleagues, partners, organisations to promote and support that and encourage as many people as possible complete and fill that in. Before further dates have been arranged for the screening and workshop of the resilience film, which relates to the trauma-informed board priority. I would urge board members who have not seen it yet to book on, and after the meeting Val will resend the link round, and the Integrated Care Board's got a bespoke screening as was discussed at the last meeting, and the date will be arranged for that as well. So the final bit is for me to say thank you. Thank you to Rachel and to Val, Chris, for navigating me and making me sitting here very straightforward and very easy, but also then to board members for also making it really easy to chair the meeting. But I've really enjoyed it actually. So the contribution, the debate, the challenge, the updates, the topic areas, I think have been really interesting, been good conversation and good debate around that. So in terms of the formal part of this meeting, I've not been notified of any other business. I can't see anybody saying they've got any other business. So I'm going to bring the formal part to an end. We'll come offline and stop streaming. What I would ask if board members could stay for a short period once we've stopped streaming to the public. There's just a couple of slides in terms of the informal update that we want to go through, if that would be okay with colleagues, but that will be quick as well, I promise. So we're about to come off live streaming, and thank you very much, everybody.
Okay.